Professor Williams again, this time with a study called Parameter, which is about arterial stiffness in the elderly.
Okay, this is the last study for this session. So these are the principal results of a prospective comparison of an angiotensin receptor neprilysin inhibitor and, with an angiotensin receptor blocker. And I'll explain what this drug is, but it's a relatively new drug, featured last meeting in heart failure, but here being looked at in the context of elderly people with systolic hypertension and stiff arteries. So in the background, systolic hypertension and increased pulse pressure, that's the difference between diastolic and systolic pressure, are indicative of artery aging and large artery stiffness. Systolic hypertension and increased pulse pressure are also predictive of cardiovascular events independently of blood pressure and an increased risk of heart failure, especially nighttime blood pressure. Large artery stiffness, as well as increasing the blood pressure that we measure in the arm, also increases the pressure in the root of the aorta, so-called central aortic systolic pressure and central pulse pressure. And these go up more over your lifetime than the pressure in the arm. So the differential between the two diminishes as you age. And this increase in central pressure reflects a worsening in the coupling between the pump, the left ventricle, and the vascular outlet tract of the aorta. And this contributes to the development of heart failure. The purpose of the parameter study was to assess the short and long-term effects at 12 and 52 weeks of LCZ696. This is this new angiotensin receptor neprilysin inhibitor, and comparing that with olmesartan, which is an angiotensin receptor blocker alone, on measures of central hemodynamics and stiffness in older patients with systolic hypertension and increased pulse pressure. Now, just a bit of background on this drug. It's a single molecular entity that comprises sacubitril, I always have difficulty saying it, and valsartan, and that is a neprilysin inhibitor. And the sacubitril inhibits the breakdown of natriuretic peptides, and these are the protective side of the cardiovascular system. They promote vasodilatation, they promote a reduction in arterial stiffness, and improve the coupling of the ventricle with the aorta. Renin-angiotensin system blockade also occurs with this drug because it contains valsartan, which is an angiotensin receptor blocker, and we already know about the protective effects of that mechanism in terms of reducing blood pressure and cardiovascular events. So the philosophy was bringing the two together would have both the protective effects of blocking the renin system and the potential benefits of potentiating natriuretic peptides in this new class of drugs, the so-called ARNI, angiotensin receptor neprilysin inhibitor. So the design of this study is simple. Many of the patients had been previously treated with conventional drugs. These were washed out, and then they were randomized to receive LCZ696, this new ARNI drug, or olmesartan, an angiotensin receptor blocker. The primary outcome was measured when they were just on these two single entities after 12 weeks, looking at central aortic hemodynamics. And then for the next 40 weeks, additional drugs could be added if blood pressure wasn't yet a goal that was less than 140/90. And at the end of 40 weeks, we had a look at pulse wave velocity, aortic stiffness, and blood pressure again. Just to say that the 454 patients randomized, they were all 60 years of age or older, and importantly had systolic hypertension and a stiff artery as indicated by a pulse pressure greater than 60 millimeters of mercury. So our hypothesis was that in these older patients with stiff arteries and an increased pulse pressure, LCZ696 will reduce central aortic systolic and pulse pressure more effectively than a standard angiotensin receptor blocker, and the endpoint was to demonstrate this at 12 weeks. We conducted this study across 48 sites in 12 countries across the world. We randomized 454 patients. Very few people dropped out. 89% of patients completed the evaluation at 12 weeks and 80% at 52 weeks. Both drugs were extremely well tolerated. So this is the key primary and secondary endpoint of this study. Central aortic systolic pressure was significantly reduced by both drugs, but a greater reduction seen with the LCZ 696, about 50% more lowering of central aortic systolic pressure. Again, if we look at central pulse pressure, about 50% greater reduction in central pulse pressure compared to conventional angiotensin receptor blockade. This was also manifest in the conventional measurement of blood pressure, much greater blood pressure lowering with LCZ 696 in these patients with systolic hypertension, where conventionally controlling blood pressure is quite difficult. We saw a 13.7 millimeters of mercury reduction with LCZ and 9.9 with olmesartan in high dose. Again, a significant difference between these treatments on systolic pressure and an even greater difference on pulse pressure in proportionate terms. What was really fascinating was when we looked at nighttime pressure using 24-hour blood pressure monitoring. Here we have both drugs looking at the effect of systolic blood pressure in the arm, the brachial systolic blood pressure, and this was significantly reduced with LCZ relative to olmesartan, a highly significant reduction. But interestingly, most of this reduction occurs during the nighttime period, a period which is known to be associated with increased cardiovascular risk if blood pressure is elevated. And for the first time, we were also able to measure 24-hour ambulatory aortic pressure using a new device in this study. And again, it replicated the finding that LCZ 696 was particularly effective relative to a standard ARB in reducing aortic pressure over 24 hours, and particularly at night. Finally, the action of this drug is to promote the activation of natriuretic peptides and therefore potentially reduce their production. And the reduction in production of BNP would be indicative of offloading of the ventricle and reducing in ventricular work and strain. And interestingly, with LCZ 696, we saw a 34% reduction in background NT-proBNP, which is the precursor for BNP in the circulation, reflecting an improvement in ventricular performance, and this reduction was significantly greater than that seen with the standard angiotensin receptor blocker alone. And just by way of reference to the previous presentation, just to show you how high risk this population is with systolic hypertension and stiff arteries, you can see that the baseline BNP level here is about 9 times higher than in the previous study we just saw in patients with background disease in Japan. We also saw a rise in cyclic GMP in the urine, and this is indicative of systemic availability of natriuretic peptides stimulating their receptors, which promotes an increase in cyclic GMP. When we look at a year, blood pressures have now come together, and that is because we allowed additional drugs to be added on over the rest of the study towards 52 weeks. But interestingly, at the end of a year, to achieve blood pressure control, patients required more add-on drugs with the olmesartan background treatment, 45% against 31% for amlodipine, 18% against 8% for hydrochlorothiazide, reflecting the fact that blood pressure was lowered more with the LCZ 696 throughout the study. And in fact, 68% of patients on LCZ 696 were able to remain just on monotherapy throughout this study, despite having quite significant systolic hypertension. Pulse wave velocity trended to be reduced more with LCZ 696, but this wasn't significant at either 12 weeks or 52 weeks, and larger studies will be required to look specifically at this stiffness parameter. Importantly, in the context of this being a new drug, the safety parameters looked impressive. There was no significant difference in adverse events with LCZ 696 compared to an angiotensin receptor blocker alone. So in summary, in older patients with systolic hypertension and an increase in pulse pressure indicative of arterial stiffening, the parameter study met its primary and key secondary objectives by demonstrating superior efficacy of LCZ 696 compared to olmesartan in lowering both central aortic systolic pressure and pulse pressure after 12 weeks of monotherapy. LCZ 696 also lowered 24-hour ambulatory systolic pressure more than olmesartan after 12 weeks of therapy, and interestingly, much of that additional benefit was seen during the nighttime period. There was no difference between the two regimens in central and brachial blood pressure at week 52 due to the allowance of add-on antihypertensive therapy in both groups. However, a higher percentage of patients in the olmesartan group required add-on amlodipine and hydrochlorothiazide therapy, indicating the superior blood pressure lowering efficacy of LCZ 696 throughout. In conclusion, Parameter is the first randomized study to demonstrate the ability of LCZ 696 to reduce central blood pressure and pulse pressure and peripheral blood pressure more effectively than an angiotensin receptor blocker in high-risk older patients with systolic hypertension and stiff arteries as indicated by an increased pulse pressure. These results suggest that LCZ 696, an angiotensin receptor neprilysin inhibitor, has beneficial effects on central aortic hemodynamics and function that could provide a therapeutic advantage beyond those observed with conventional renin-angiotensin system blockade. Thank you.